All right, everybody, Dr. Shaddy, a rapist from Vet Triage. We are going to be talking about horses today, the ultrasound-guided tenoscopic decompression of digital sheath synoviocoeles in 10 horses. We're going through this issue of Veterinary Surgery from February 2022. And just to get you prepped for what's to come here with this study, we're focusing on the superficial digital flexor tendon here. That's the main goal. So we're going to talk about that. But here are the rest of the anatomic structures of the distal limb of the horse. This study comes out of the Royal Veterinary College in the United Kingdom and 2 veterinary hospitals in the UK as well. The objective is to report the diagnostic features and clinical outcomes of horses with digital flexor tendon sheath synoviocoeles treated tenoscopically under ultrasound. Results found that lameness and synoviocoeles were unilateral, so 5 forelimbs and 5 hind limbs, 3 were lateral, 2 medial in both, and located proximal to the palmar plantar annular ligament. Synoviocoeles had a firm consistency and focal pain with inability to deflate on non-weight bearing examination. Intrathecal digital flexor tendon sheath anesthesia was positive in 7 of the 8 horses in which it was performed, with the remainder localized to the region of the synoviocoele using perineural and or intralesional anesthesia. Communication between the digital flexor tendon sheath and synoviocoele was suspected on ultrasound in all cases and confirmed on contrast tomography. Tenoscopic fenestration of the communication between the digital flexor tendon sheath and synoviocoele under ultrasound with treatment of concurrent intrathecal injury in 4 out of 10 horses, resolved the lameness in all horses, reevaluated by a veterinarian, and allowed return to full athletic function in all cases at a median of 5 years of follow-up. Introduction. Non-septic tenosynovitis of the digital flexor tendon sheath is a common cause of distal limb lameness in the horse. The sheath contains and is in close association with important anatomic structures that are commonly injured, including the superficial digital flexor tendons, that's the picture there, the manica flexoria, the deep digital flexor tendon, that's right here, the palmar and plantar annular ligament, and then adventitious fluid-filled structures have also been associated with the digital flexor tendon sheath. These lesions have also been called synovial ganglion cyst, synovial hernia, adventitious bursa, and synoviocoele, a fluid-filled cavity without a synovial lining and surrounded by inflammatory myxomatous change is what's seen on biopsy. Synoviocoeles have been associated with a number of different synovial cavities, but only some are believed to be cause of lameness, like the ones affecting the tarsal sheath and the digital flexor tendon sheath. One of the mechanisms proposed for pain arising from this cyst has been a one-way valve arising from limited communication between the parent synovial cavity and the synoviocoele, which results in a progressive increase in intralesional pressure and an inability to deflate. This increased pressure has been hypothesized to cause irritation of surrounding tissues like the neurovascular bundle, resulting in pain. Previous approaches for digital flexor tendon sheath synoviocoeles have ranged from extrasynovial excision with closure of the defect and successful conservative management with intralesional corticosteroid and atropine injection. Fenestration of the synoviocoele opening will convert the unidirectional flow to bidirectional, reducing intralesional pressure and pain. A minimally invasive approach for treatment of popliteal cysts in human knee joints, and the subsequent description of successful treatment of tarsal sheath synoviocoeles using tenoscopic enlargement of the communication prompted the development of the same approach to treat digital flexor tendon sheath synoviocoeles. Materials and methods. These cases were from April of 2011 to March 2019. For surgery, in all cases, tenoscopy was performed using a 4mm 25-degree forward oblique arthroscope introduced into the sheath, outpouching located between the palmar or plantar annular ligament and proximal digital annular ligament, immediately palmar or plantar to the palmar or plantar digital neurovascular bundle. Cases that had a palmar or plantar annular ligament constriction underwent a desmotomy performed under tenoscopic guidance with a hook knife. Intraoperative ultrasound was used to guide and confirm the introduction of the synovial resector. For perioperative and postoperative care, the horses received either flunixin, meglumine, or phenylbutazone, along with procaine, penicillin, and they had sterile bandage changes done. So here is a picture there. The white arrows in both pictures is the apparatus that they're inserting into the cyst. A shows the asterisk there, that is the cyst, and B shows the placement of the surgical tool to fenestrate the cyst in the actual cyst itself. Follow-up information, median of 5 years, with a questionnaire sent by email or phone to the referring veterinary surgeons or the owner. The results found that the horses were a median of 12 and a half years old. Most were geldings, 5 were cob-type horses. Duration of lameness had a median of 2.5 months. 7 horses were used for general purpose. Clinical findings include that all synoviocoeles were located adjacent to the proximal aspect of the digital flexor tendon sheath, just proximal to the palmar or plantar annular ligament. 5 of these synoviocoeles were located in the forelimb, 3 lateral, 2 medial, and 5 in the hind limb, 3 lateral, 2 medial. As far as anesthesia, it improved lameness in these horses by 70 to 90%. That's subjective, of course. They also did contrast tomography and ultrasound for a workup. As far as surgical findings go, here is the appearance of the horse's limb. So the arrows point to the swelling, pretty obvious there. And then the ultrasound images there. The arrow in the top picture showing the synoviocoele. In the bottom picture, the arrows point to the synoviocoele, and then there's a very small asterisk that shows communication with the sheath, or at least suspected communication with the sheath. Okay, outcome, all horses returned to soundness. Yay. All right, discussion. An important advantage of an intrasynovial approach to treating synoviocoeles rather than extrasynovial without tenoscopy approach is the ability to identify and treat concurrent intrathecal injury, which might have been overlooked otherwise. The fenestration technique also avoids the risk of synovial leakage into the subcutaneous space after a surgical excision when the opening is not closed adequately. These results compare favorably to other case series for the treatment of synoviocoeles where extrasynovial excision also resulted in a good outcome in 88% of horses returning to previous levels of work, and a tenoscopic approach for the treatment of tarsal sheath synoviocoeles showed clinical resolution and return to work in 66% of horses. And that's it. So, yeah, I mean, you need more horses, obviously. They know that for these types of retrospective studies. Otherwise, very cool, minimally invasive technique to fix what seems to be a very common issue with horses. All right. Thanks for supporting the channel. We'll see you again tomorrow. Bye-bye.